and procedural sedation. So we've decided to take a case-based approach and just touch on a few things in more detail rather than doing too much. Take some questions at the end, and hopefully we can make it interactive with the polls and a couple questions in between. Okay. So, can we move the slide? Thank you. Okay, so this is Johnny. Johnny's 3. Johnny's been a little bit upset by lockdown. He hasn't been able to go to the park and play on the jungle gym. So he decided to play on the bunk bed instead, fell off. He's been brought to the EC by Mum. Mum is very concerned that he's not moving his arm. So you see Johnny in your EC. One of the interns has come upon him already and secured, will make sure his ABCs are secured. And you see that Johnny's in quite a bit of pain. And you want to address that quite urgently, as quickly as possible. And you're waiting for that drug cupboard key. Let's talk about some of the non-pharmacological interventions that you can try while you wait for the drug cupboard key.
Okay, so whenever we say non-pharmacological interventions, emergency medicine people are normally like, oh gosh, okay, no, really now, leave that to the pediatricians. This child's got a broken arm, like really now, let's just cut to the chase. Well, I think we can all acknowledge that, you know, a child with a severely broken arm or a very painful injury is going to need some pharmacological interventions, but there is a lot that we can do to help. Going through the basics, non-pharmacological interventions are always the first line of pain management. Now, we know that for an injury like this, we're not going to stop there, but don't underestimate the importance of these in children. Number one, completely safe, but does differ according to the child's age. One of the really basic things that is really underestimated is not letting the child see scary things. You included are one of those. But people end up doing things like drawing up drugs, opening needles, syringe packets, medical gadgets, all sorts of things in front of the child, which obviously is very scary and intimidating. And so the way that the child is positioned or held in the emergency center should be with that in mind. So basics, if a child can be managed on a parent's lap or whilst being held by the parents, that is always top choice. Now, we know that's not always possible based on all injuries, but initially, certainly, child on parent's lap with the chair turned in such a way that the child is not looking at healthcare workers or scary things. So have the chair turned so that the child's looking out the window, looking at a mural on the wall or whatever you've got up, pretty posters. There's things that the parent can already start. Distracting things, give the parents a job. Parents are often terrified, they're freaking out, they're incredibly worried, they must do something. Give them a job and involve them. So tell them, you know, mom or dad or whoever the caregiver is, please, you know, you can distract the child. A lot of parents have got a phone with some kind of video, photos, something, music that they can play to the child and encourage that from the parent. So, you know, in first world settings and all over, there's some places have got people that are literally employed as play therapists and whatever. Clearly that's not available in our context, but you can certainly give the parent the job of the distracting. So suggest what they can do. Don't you have any videos on your phone you can play? Often they do. And distract the child while we're busy with other things. Also, other non-pharmacological interventions that are super basic. Don't underestimate how much analgesia simply splinting a very badly broken arm can provide. Putting the arm in a splint or in a sling or some kind of technique to immobilize the joint, will prevent that bone from moving on each other and worsen the pain. Other things, children that have bled, often they've got a minor injury, but they've bled quite a bit on their white t-shirt, whatever, that the sight of blood can be scary. Cover it, hide it, throw away the, put out of view the bloody t-shirt or whatever, because all of those things contribute to the child's pain. There are other things that can be done, depends on the type of injury, but applying cold or applying heat on certain types of injuries can be distracting. Don't underestimate what the parents can perform and also involve them. If the child is unable to be on a parent's lap and they need to be on the bed for whatever reason, consider the way that you set up your bed being such that the head of bed is furthest away from the wall and feet of the bed about the wall. Even with quite severe injuries, propping the chair for the parents to sit at the feet of the bed, if the feet is against the wall, it actually puts them completely out of your way, because you don't need access to that part of the child. And so if the bed is turned, they're sitting up, they're looking at the wall, looking at the sort of monitor side of things. They're not looking at nurses and doctors walking past, and they're looking at the parents that's by their feet. That can be distracting, talking to them, playing music for them while we're busy doing our thing. Okay.
Cool. So children are not all the same. I know we like to say that they're not adults, and they aren't adults, but a neonate is a very different creature to an adolescent, and yet they're all pediatrics. So just a quick reminder that your drug dosing and your drug options and your frequency is going to change a lot with the age of your child that you're seeing. Their body compositions, their physiology, their fat stores, all of that changes quite a lot through the different age groups, as well as their response to pain and the way they express their pain. So you just need to take that into account when you're deciding which drugs that you're going to use, how often you're going to use them, and how you're going to dose them. Just a little note on the neonate. A lot of the time we see neonates not just for injuries, but for procedures. For example, a lumbar puncture or something like that. So don't forget about types of analgesics that would help with that sort of thing. So, for example, EMLA before your lumbar puncture. Sucrose is a wonderful, I don't know if I can call it drug, it's sugar, which I guess is a drug, but it's a wonderful thing to use for a neonate, a 30% sucrose solution on a dummy. When they suck it, they release dopamine and they distract it, and that can help with small procedures that we do in the emergency center. And then, just to remind you that physiology does change with age, so just keep that in mind. We can go to the next slide. Okay, thank you. So who is doing what for weight? Is anyone weighing their babies when they come in?
Yes.
Take that as a no. Yes?
Yes.
Who was that? Okay. I think that's first prize. And actual weight, I think, is first prize. There are a lot of formulas that were given to use to estimate weight, which we used to use quite a lot. We used to rely on those quite a lot. And then we got the Breslow tape, and we used to use that. And now more recently, we've got the Pauper tape available in South Africa, which is validated for use in our population and is very affordable. So I would probably recommend using this over a Breslow or a formula, unless you have an actual weight on a patient. You can buy them online. They're very cheap. you should probably just get a couple and keep with you, or have one in your unit, put it in the top drawer of the resus trolley and have it there available for you. Yeah.
Okay, so just moving on, just to say how affordable they are. A lot of people don't know the pauper tapes are 15 Rand, 1-5. So please, just like maybe as a group of registrars, if we don't have one of you buy 20, and then everyone could just get them off, because it's 15 Rand. It's super, super cheap. You don't have to depend on the particular hospital or clinic or wherever you're working to have one, and it really makes a big difference.
I spent 15 Rand over tape, please, Doug.
Oh, she said you must buy more than that, though. So it's going to be like...
I can hear whoever's speaking. I don't know who it is. Okay, so 15 Rand, maybe you can buy a whole bunch. The pauper tape version 2 is a bit more expensive. I think it's like 30 something Rand, but really the number 1 is fine. Okay, so just moving on to different...
We're not doing advertising for Mark Wells. They are really good.
So, right, so people are traditionally really, really bad at assessing children's pain. So children have pain, and I can't even tell you how often we step into resus or peds or wherever, and you find that a child has got a bad injury and they've had paracetamol. And it doesn't matter what the injury is, how mild, moderate, or severe it is, they've had paracetamol. And if you fractured your femur, you'd be quite distressed if I gave you 2 paracetamols, and therefore you should be equally as distressed about children. But it's because of fear. People are afraid of giving medication in children, and they're just comfortable, and they get told by people that's just what we do here. Sometimes if it's very painful, they get some brufen also. So we really need to think about stratifying the pain. Now, what we're not going to go into in this talk is detailed pain assessment in children, because that's a whole hour-long talk on its own. But when we're talking about acute pain, essentially, this is a real Candice and Kat basic take-home, is you're going to have mild, moderate, or severe. Severe, badly broken bone. Mild, well, a small little laceration on finger, and moderate, somewhere in between. And I'll let you figure out exactly how you're going to decide which patients fall into those categories, but we've got a very basic way of thinking about it. So mild, moderate, severe. Mild, I think everyone is fairly comfortable that, okay, we're going to give some paracetamol here. Now, just give you a warning about that. Often a big mistake that's made is that you get told, you come to see the child, and the nurse has already said they've already given Panado, or the mom says she's already given Panado. Don't always check what dose has been given, and is that appropriate for the child's weight? Because I do a poll here, but it'll be a unanimous answer. If you ask almost every nurse working in peds triage or wherever the place is, how much Panado they did give, they'll tell you 5 mils. Whether the child weighs 10 kilos or weighs 100 kilos, the child gets 5 mils of Panado. So please make sure that the dose given is appropriate. And the same goes for mom. Mom gave, or dad gave paracetamol at home, and just check if that's an appropriate dose, and top up to the correct dose if needs be. We have to treat pain in a stepwise manner. That being said, we're not going to give Panado to a fractured femur and wait 2 hours for a response. We have to be rational based on the type of acute injury. So looking at mild and moderate and severe. Going through mild and moderate first, we're going to go through some oral options. So first of all, paracetamol. So for a mild injury or pain, an acute pain of some sort, we'll start with our paracetamol and wait for a response. If there's no response, you could add ibuprofen syrup to that. Small little things. I'm going to talk state sector. We are also going to mention other options that are not available in our sector, just to give you a bit, broaden your horizons a bit. But in state sector, actually, brufen is surprisingly hard to get in an emergency center, because on code, it's only on provincial code for post-operative pain. So if you're working in a center, or you're about to qualify as a consultant and you're going to be going to go work somewhere, find out if that's the case at your hospital, that it's not stocked. And you can easily motivate to pharmacy that you do small operative procedures in the emergency center, and therefore it should be stocked in your emergency center. So that's just a trick of the trade for those of you working in state to make sure that you've got your ibuprofen syrup stocked. So a paracetamol, move on to ibuprofen if no response. Then you're looking at your moderate pains. Now your moderate pains, you're still going to, now this time, instead of giving paracetamol and then ibuprofen, you're going to recommend multimodal approach. So you're going to give paracetamol and ibuprofen, obviously as long as there's no contraindications to these drugs or contraindications to oral administration of any medication. So you're giving paracetamol and ibuprofen, and then you can go on to give another option if there's not a response to those two medication, and that option is Valeron. Now, let's do our first poll. What is Valeron? So some of you have used it before, some of you haven't. It's drop. Okay, so let's see our first poll. So benzo, opiate, NSAID, other, or number 5, prefer not to say. So let's get some votes. Okay, we're going to give 5 minutes. This is a musical interlude. Candice is going to provide you with some interpretive dance. We've got 6 responses. Let's give everyone one more time. So Valeron, the other name for Valeron is Tilidine. So the correct pharmacological name is Tilidine. But if you ask for Tilidine in the emergency center from the nursing staff, you're going to get blank stares and say, we don't do that here, we don't have it. We're on 8 responses now. It sounds like silly questions, but you know these are basics we need to know. So let's see. So we're talking about moderate pain now. We're going to give paracetamol and ibuprofen, and then see a response. If not adequately responding, then you're going to give this is our suggested option for your moderate pain if not responding to the 2 meds in combination. Okay, 9 votes. That's all I can see. Okay, go to the chat if you don't know where we are. Go to the chat. Okay, we're on 10 responses. Some people are just waiting to see what the consensus is and then they're voting. Don't worry, it's anonymous. We can't see who's voting for what. Yeah. 11 responses. Okay, we seem to have a fair consensus.
Yeah.
Okay, all right. Okay, so the consensus seems to be option 2, opiate. This is correct. It is an intermediate acting opiate. All right. Let's go on. I don't know if there's how we do this. Cameron, can you reset that the quiz for us, please? So we're going. Okay, so.
Yes, we can't really reset it. Sorry, Kat, we can't really reset it, but it just means that next time when people vote, if you did vote before and you prefer to not vote, please say prefer not to say. If you haven't voted before, then just re-vote.
Okay, so right. So what is Tilidine? Tilidine is also known as Valeron drops. It's an intermediate acting opioid. It's administered sublingual or inside your gum or tooth margins. Okay, so just be warned about that because a lot of nursing staff don't know this. A lot of nursing staff mix it with the Panado or otherwise just give it as an oral. So technically it's supposed to be sublingual or inside the tooth margins. So if you're going to be giving an oral med, the oral med should be given first, allowed to swallow, and then go on and give. Now it's a little bit bitter, so that's why some of the nursing staff prefer to give it in paracetamol. So I think just assess it on your thing. But ideally it should be given as sublingual, otherwise it will take longer to start working. So time to peak is 45 minutes until peak effect. So that's something to bear in mind when you're assessing your pain, is that the time to peak action is 45 minutes and your duration is 4 to 6 hours. This is a very, very useful drug in the emergency center. You don't need IV access. You don't need high-level monitoring. such as you will with a rapid-acting opiate. This is a very, very good option. 45 minutes to optimal effect. You've got a very minor little wound that needs to be cleaned and dressed. You want to sort out the pain first. Bear in mind the 45 minutes till peak effect. Okay, so now dosing. Let's look at our votes there. Okay, now this is a little bit of a tricky thing to do. Let's have a look what we're looking at here. Candice, what do you think consensus is there?
Has everyone voted?
Definitely not.
Well, not everyone, but those that are going to vote.
Okay, cool. So we seem to be somewhere. Option 3 seems to be consensus, but there's definitely not such consensus as the previous question. And we seem to be somewhere between option 2 and option 3. Okay, so the correct dose as per SAMP and various prescribing guides is 1 drop per 2.5 kilograms of body weight. That is a little bit tricky to do those maths, and we'll talk about how to get around that just now. So option 3 is our correct answer. Option 2 is not far off, but option 3 is our correct answer as per the textbooks. All right. So moving on, if I can, there we go. All right. So how do we sort of get around some of these challenges of dosing and underdosing? So highly recommended to have a dosing chart available everywhere in your pediatric section of your emergency center. Have a dosing chart nice and easy. Drug errors are a significant thing with children. You've got sometimes very junior staff, ComServes interns, managing children, nursing staff that might not have worked with pediatrics before. A big thing. If you've got a nurse that works with pediatrics a lot, they've administered thousands of doses to children. When a doctor writes up a dose that's off, that's an incorrect dose, that nurse will often pick it up. They say, "Doctor, that seems like a lot of drops for this size child." However, you might have nursing staff that are not experienced with pediatrics, and it's just important to note that having a dosing chart like this makes things very easy. You can quickly palpitate, measure your child, or weigh them, and start medication. So this is just pre-calculated doses. And you can consider in your relevant department initiating a protocol where there's nurse-administered medication, where you don't need to wait for a doctor to prescribe paracetamol and ibuprofen with certain types of injuries. So as future consultants or head of departments, think about initiating a nurse-initiated analgesia protocol in your department. So they don't wait until the doctor's seen the patient and when there's 30 patients waiting to be seen in the peds area. All right, so think about a chart like this. All right, now going on to severe. Now this is where it gets interesting, and this is where often people stop. Paracetamol, ibuprofen, Valoran drops, and then that's it. Then the next step is nothing. That is quite frequently what happens in many, many emergency centers, and this is where we go wrong with children, because in adults we wouldn't stop with just 3 oral agents, we'd try something else. Okay, so what is our next option? So acknowledging that opiate analgesia is our next step, we need to talk about fentanyl and morphine. So this is our favorite, okay? We have it available, acknowledging that not all places have fentanyl available, and not all places have intranasal as an option. So our intravenous dose for children for analgesia is 0.25 mics per kg for intravenous. However, we really, really, really want to strongly punt for the use of intranasal fentanyl. This is internationally where everyone is moving towards, and it is an absolutely great option. Okay, so before we talk about more, I'm just going to play you a short video. Candice, if you could just give me a thumbs up.
The LMA Mad Nasal is the safe and painless way to deliver medications directly into your patient's bloodstream without an intravenous line. To use the MAD nasal, fill the syringe with the proper volume of medication and connect the atomizer. Place the MAD nasal gently but firmly against the nasal opening and briskly compress the syringe plunger. The medication exits the tip of the MAD nasal as a fine atomized mist, resulting in broad coverage of the nasal mucosa with a thin layer of drug. The medication rapidly absorbs across the mucous membrane into the bloodstream, as well as directly into the cerebral spinal fluid of the brain, avoiding first-pass metabolism. This achieves medication levels comparable to injections. Once in the bloodstream, the medication circulates throughout the body. In the central nervous system, it enters the brain and binds to neuroreceptors, exerting the desired clinical effect and leading to resolution and improvement in the patient's symptoms.
Okay, so intranasal fentanyl. Let's talk a little bit about that. So absolutely great option. You don't need a needle yet. You've got a child that is distressed. You've now distracted them nicely. You've positioned them appropriately in a department. You've given them oral medication as it's appropriate in that particular child. But you've decided that this is severe. So you've given some paracetamol, some ibuprofen. The nurse has already initiated that before you walked in the door. And you realize that this child is in severe pain. And we're not going to go with our Tilidine or Valeron drops because it's going to take 45 minutes to reach peak effect. This child needs help now. Now, a lot of people at this point might put up a drip and give intravenous morphine, if the child's lucky. But we're going to really, really punt strongly for intranasal fentanyl. Whole lot of benefits. Number one, it is quicker in general. Now, you could say, but I can just quickly put up an IV line. It's fine. So I'm going to show you
the LMA MAD.
Okay, all right. So there's a couple of benefits for the intranasal versus IV. Now, this is a theoretical example. This is not a particular opiate. This is not fentanyl necessarily, but this is a comparison of intravenous and intranasal. Our big concern in children, and which is what gives everyone the fear of opiates in children, is respiratory depression. This is the number one fear of so many clinicians, is respiratory depression. Now, if you look at your therapeutic efficacy versus your respiratory depression, the way the drug is absorbed by both blood-brain barrier as well as the nose CSF pathway, which is an actual thing, is that there is much a slower curve. Now, you could say, but look, you've saved, there's 4 minutes if you give it IV. Well, I challenge you. I really don't think by the time you have got your hip lock flushed and your tourniquet on and everything else, there's no way that you'd already have, you would be able to beat, this 3 minutes. So if you look here, you got 3 minutes till it starts reaching therapeutic threshold. We're sitting at about 10, 12 minutes before you reach sort of peak effect. But you do start to have response earlier. So intranasal fentanyl, absolutely excellent option. Now, a couple of pearls of wisdom. Number one, you should never dilute an intranasal drug. An intranasal drug should always be given neat. You should not be giving more than 1 ml per nostril. Now, for the very simple reason it'll run off and be swallowed. Okay, so that's one of the reasons why you shouldn't dilute it. Fentanyl, in that note, is a very good drug because it is very concentrated already. So the amp is already small. So don't dilute your drug. You might need to give half in each nostril if it is a higher volume drug. Very important. The back, doesn't matter how cooperative the child is, when they start getting spray in their nose, they will naturally flinch and move backwards, and then you'll spray the drug all over their face. So always have a hand on the occiput, okay, and spray that way, so that you've got a controlled thing, and preferably on their back. You could still do it on a parent's lap, but they should preferably be on their back with their occiput supported and not sitting in the upright position. Excellent option. And as well as for the respiratory depression, less concern. All right, so let's go on to our next quiz. All right, so we already mentioned the IV dose of fentanyl. Now let's have a look at consensus for the intranasal dose.
Are people voting?
Let's see. I'm going to need Camlin to help me interpret these results as the pro on this thing.
Yeah, people are voting, so the numbers are changing. So I think we just give it a... Just please, everybody, if you have voted before, you are obliged to vote again. Otherwise, it messes up our consensus. And if you feel like you don't want to put any one of these options, maybe just enter the prefer to not say.
And then there was a little note from Kagiso saying he was battling to hear. Is anybody else having issues hearing?
Candice, can you hear me fine?
I can hear you.
Camlin, you stop us when you think the voting has come to an end, and you can give me what you think the consensus is there.
Okay, we'll do. So far, we've got 20 responses, and it seems to be that the predominance is for option 2 and then option 3 with 42% and 38% respectively. Option 1 is favoring in the least popular option with just 4% being one respondent. Should probably announce it like a horse racing announcer.
Yeah, you carry on with that. You try that. Okay, so all right. So dosing. The literature varies on the intranasal fentanyl dosing, but generally seems to be between 1.5 to 2 mics per kg. All right. So there is no right and wrong answer here, but generally the consensus based on international experience and international protocols and guidelines for analgesia for children, somewhere between 1.5 to 2 mics per kg. This makes some people feel very uncomfortable because they're used to giving the 0.25 mics per kg dosing IV, and then that can make people a bit uncomfortable, but this is your dose. It's significantly higher. Just like in oral, not the same as oral dosing, but just like in oral dosing, you have to dose differently when it comes to mechanism of action. Okay, so all right. Before, let me go on from here. See if I can get control back. Yes.
Can you see the message there from Natalie?
No.
You want to just tell her about the atomizers?
Yes. Okay. All right. Yes. So atomizers. I'll share the resource afterwards, so you can give it to consultants in various departments. These, not what's on the screen. What's on the screen is just a syringe. The atomizers, this brand, the MAD atomizer, is a state tender item and can be ordered off state tender. They are super, super cheap. I think they're cheaper than a Gelco. And they're a state tender item. So this is not some fancy thing that you can get only with special budget and permission. It can just be ordered, just like any needle or syringe or whatever can be ordered. A lot of people don't know this. So I'll give the state tender document, which relevant people can take to your consultants and departments and can they can order via their supply chain process. So very, very easy. Ideally, it should be given with a proper atomizer, not with a little Gelco on the end trying to make a spray. It doesn't work as well as the proper atomizers. Very, very easy to use. What else? It also helps you calm the whole situation down. You've got a child in severe pain. We've distracted them. We've acutely managed their pain. Because a lot of people are like, oh no, let's find the child. Let's just drip the child, give the ketamine, reduce the fracture, do the whatever. But the problem is they put the drip up, then they send the child for an x-ray with their Panado briefing board. The x-ray is incredibly painful because they have to move the elbow a certain way to get us the beautiful views that we like. And the x-ray is a very painful procedure, and yet we haven't provided good analgesia. So all very well to say, let's just drip the child, but often people just send them with their hip lock to x-rays, and then they're going to give the ketamine later for sedation. So we'll talk about that further on when we get to the sedation part. Okay, so on that note, you have given your intranasal fentanyl, and you're going to send them off for x-rays, but you can see that it looks really displaced, and is probably going to need some sort of sedation for the procedure. The intranasal fentanyl is an analgesic. That's not going to be enough to do the full procedure. So there are some other options you can give in the state sector also before the child goes to x-ray. So amethicane or Emla cream, local anesthetic creams, can be applied so that later on, when you are going to drip the child and give our sedative medications, we have a much more pain-free emergency center experience. So there's a whole lot of questions about this. People say, okay, bar humbug, just drip the child. Like really, we don't have time to waste for these things. Well, actually, timeline-wise, if you put the Emla cream on then and there, straight after you've given some intranasal fentanyl, by the time they've got the folder, gone to x-rays, come back from x-rays, a nurse has done some observations, put them on some monitors, actually your creams would have started working. But now let's talk about this. So these are two different options. Emla's on state tender, amethicane is not, but can be purchased at what they call a buyout item. So let's do our next quiz. All right. So Emla cream takes how long for optimal usage? Okay, while people are voting there, I can see there's some more questions that have popped up. Is it reusable? Okay, so technically it's a single-use item, but it is going in someone's nose. It is not an intravenous medication. You'd never use a syringe again. So the atomizer itself comes with a syringe in the packet, and the syringe can be thrown away, and you can use any 2 ml syringe with the atomizer. Now the atomizer itself, it's just a cushion, and then on the outside, which could be wiped in theory. And I'm not saying that you can reuse them again, but if you think about it, it can probably be well cleaned, I'm guessing. And I will not say anything further on that because technically it's a single-use device, but I'll let you use your practical common sense. But they are super cheap. They're under 10 Rand. There's lots of other things that cost under 10 Rand that you don't reuse. They are not expensive items. So how's our vote going? Okay, can you do intranasal fentanyl and top up with ketamine? Yes, is the answer to that. You can do intranasal and fentanyl and a lot of things. If you think about it, it's an opiate, it's different action altogether. You don't have to go give a thing, but we're going to talk more about ketamine a bit later. Yes, the two drugs can be given together, including if you have an IV later on, if you want to give ketamine as an analgesic agent later on, not just as a sedative drug. We'll talk about that. So what's our vote, Camlin?
So voting has occurred. It looks like there's a relative split between option 2 and option 3, that being 42% saying 15 to 30 minutes and 47% saying 30 to 45 minutes.
Actually, Emla cream is optimally 60 to 90 minutes for onset of action. So if you want to truly wait for the optimal time, it's 60 minutes. And I don't know about you, but our efficiency is not often such that we are fully ready to, we can often send them for x-rays, open the folders, they've had their fentanyl. There's no longer a rush for the sedation because the pain is under control. The child is calm. We've splintered the arm. We've made them comfortable with enough. So actually 60 to 90 minutes is the answer. You should ideally be waiting for 60 minutes. That doesn't mean it doesn't start working earlier. It does start working earlier, but for your peak effect, 60 minutes. Just to put this into context, we occasionally have children that need pleural taps in the emergency center. Your bigger kids, 8, 9 years old with possible TB, the pleural effusion, I can do a pleural tap with Emla cream, and I've had one child that told me they didn't even notice that I'd done the procedure because you waited a proper 60 minutes with a good blob of Emla on, secured with a tape dressing. So 60 minutes, absolutely great. Now this is also for yourself, your own family, whatever else. So then The next question is, okay, so amethicane, yes, we don't have it easily available, but just so that you know, timeline-wise, amethicane is 30 minutes, whereas EMLA is 60 to 90. So amethicane, if you're buying it cash out of your own pocket, we'll talk about just now, but it's this is 30 minutes as opposed to the 60 minutes. So already timeline-wise, it's better. Okay, so I seem to have the slide repeated many times. I don't know why. Okay, so then what about cost? Because everyone says these things are expensive. Well, it's not on our budget. We've got to watch out for the budget. We can't be using EMLA for every kid that needs a drip. Just to put into context, price-wise, EMLA cream is 66 Rand. This is if you buy it from Dis-Chems. This is not state tender cheaper prices, because state does get it for cheaper. But if you buy it from Dis-Chem, it's 66 Rand for 5 grams. That equals 13 Rand and 20 cents for 1 gram. And 1 gram is kind of a blob, like under a opsite, okay? So 1 blob is about 13 Rand of EMLA. Amethicane, if you buy it yourself from Dis-Chem, is 36 Rand for a 25 gram tube. That means it's 1 Rand 40 for a 1 gram blob. So 1 Rand 40 for a 1 gram blob. Okay, and if you worried you might miss the IV line, you want to put 3 blobs on at different places on the child. We'll talk about dosing just now. That would be then 4 Rand 50 of amethicane. Now, 4 Rand 50 of amethicane, an IV admin giving set for your ringers or whatever else costs 13 Rand. So just put that cost into perspective on and what benefit is gained to the child in having a more pain-free emergency center experience. So that's a cost thing. Let me just look if there's any more questions coming up. Okay. All right. So next thing about this. Okay, the poor man's lignocaine and gauze. I can't really comment on that. I've got basically no experience with that. I've never tried the lignocaine on gauze, and I don't know the dosing, so I'm not the right person to answer that question. And then EMLA cream.
So Emily, for open wounds, that definitely works. I've never used it on closed skin, but for open wounds, it works great.
So there's also LAT for suturing, which is a different thing. That's local anesthetic. There is a specifically designed one that can be used for suturing. Red Cross Trauma I've got available in the fridge. It's there, believe it or not. No one uses it, but it's there. Should be used. So still can there. Be. Is it still there? I don't know. It's been some time. So LAT is a great stuff. It's put inside the wound so that you don't have to give lignocaine for suturing. So that is different to EMLA and amethicane, but that can be used. And then the other question is Emdocaine versus xylocaine spray. Xylocaine spray more for your mucosal type surfaces rather than skin. My preference for skin for an IV line would be EMLA by far. And it's cheap and it's available. Some hospitals will tell you we only have it available for, the pharmacy will say, no, it's only for oncology children. You just need to push a bit harder. A lot of pharmacies don't realize that you don't need to use 1 tube per child. They actually don't realize that. When they realize you can use 1 tube for 5 children, then suddenly you have agreement. Again, this is something you can advocate for. Just because it's always been done a certain way doesn't mean that's the way it has to be forever. So advocacy is important in assessing children's pain and the experience in the emergency center. Okay, so moving on, what's our maximum doses? This is EMLA only, and this is not amethicane. But just to put this into mind, this is something you should know with regards to safety. Well, 1 gram is 1 blob. So if you're using it for a neonate, well, then 1 blob. 2 blobs for a child under the age of 1, and a bigger child, well, lots of blobs. Okay, that's the summary. All right. Just to talk about some other options. Candice?
Okay, so does anyone know what this is? You can turn on your mics, or you can put something in the chat. If you don't know what it is, that's also fine. Yes, Penthrop. Penthrop, yes. Have you guys worked in private? Where have you found it? Yeah. In private, okay. So it is Penthrop. Its proper name is methoxyflurane. It's an inhaled analgesic that's administered as a single-use via disposable inhaler. I've not come across it in state sector, but I did a bit of work in private and I used it quite a bit. Then it works amazingly well. It is an anesthetic agent that they used to use as an anesthetic agent, and now they've put it into the single-use disposable inhaler, and it gives a much lower dose of the anesthetic agent, and it's great for rapid onset of very good analgesia. It's effective, it's well tolerated, the patients love it, and it provides a very rapid onset of analgesia. It's very safe. Adverse events are usually brief, self-limiting, and it doesn't usually affect your vital signs or your consciousness levels. So if you do ever come across it, it comes with that little vial that's got the Penthrox written on it. That's liquid inside there, and then you would undo that little lid and then throw the liquid into the top of that see-through container at the top. You can kind of see there's a little hole at the top there. That liquid then goes down into the green chamber where there's a wick inside the green chamber, and it gets absorbed by the wick. And then the patient, they call it the green whistle, because the patient will then put it into their mouths and inhale and exhale through the green mouthpiece. The fumes then go back out again into that little charcoal chamber, so that you don't intoxicate the rest of the staff. Usually about 6 breaths gives really good analgesia. Often they come with a little, like a little tie, little cotton tie that goes around the hand, and then the patient takes their few breaths, and then once they're feeling a bit better, their arm just kind of falls to the side, and they still have their green whistle with them. And then when they have more pain, they take another few breaths. Yeah, it's been used in Australia pre-hospitally for years and years and years, and I think more and more use will come in South Africa. What else can I tell you about it? It's great analgesia. It's very quick, very safe, and it's self-administered. So it helps, and it can buy you a little bit of time to get your x-rays or to put in your line while you've given that. For very small children who might not be able to coordinate doing the inhalation on the little mouthpiece, you can put that little mouthpiece through a bag, and you can just hold the bag on their, sorry, not a bag, a mask, on their faces, and they can inhale through there. Sorry, Jonathan, I'm just looking here. Yes, you can do that. Exactly. So that's that. So in case you come across it in a different place that you might work or an exam, that's what that is. Okay, so let's go back to Johnny now. Johnny comes back from x-rays. These are his x-rays. You are well trained in pediatric orthopedics, and you recognize that Johnny's injury is going to require a reduction, probably in the emergency center. And so you start thinking about options for procedural sedation. Our next slide. Okay, so let's summarize. So Johnny's 3. We've given him a splint. We sent him off to x-rays with oral Panado, oral ibuprofen, and we gave him a dose of intranasal fentanyl. So his pain was very well controlled before he went off to x-rays. At the moment, he's still managing quite well, but you anticipate his reduction being quite painful. injury looks quite sore. So you chat to his mum, and she's quite happy to consent for procedural sedation for the reduction of the injury. Let's just go through a few things on preparation before we get to what we would use. And Cornell, this is your time to shine. Are you there?
Yes, I'm here. Hi guys. So I'm just going to talk about fasting in with regards to procedural sedation. So firstly, just to note where it comes from. So NOPA's guidelines was first developed in 1946 by Mendelssohn, and it was done with regards to obstetric patients undergoing general anesthesia. So if you understand where it comes from, it's quite clear that it does not really apply to our patient population we're talking about. In 1980, the ASA developed their own guidelines, which is roughly what we've been using. Although that has also been developed by anaesthetists within a controlled setting where there's no time constraints really for them. It's usually for planned procedures, and in the EC, our patients present unfasted, and it's quite urgent procedures that we do. So the topic of whether we should be adhering to fasting guidelines as set out by the ASA has been quite topical in the recent years. And in 2018, Green did a big an editorial piece about it and whether we should be using it in the ED. They, in 2019, conversed a consensus meeting where they had lots of specialists, anaesthetists, emergency physicians, pediatricians, and then pediatric emergency physicians. And they reviewed all the literature regarding fasting in the pediatric population as it pertains to the emergency centre. They reviewed a lot of cases and they did an extensive systematic review, and they only found 2 incidences of aspiration in patients associated with procedural sedation in the EC. It is of note that both of these patients were fasted for more than 6 hours, so in essence met the fasting criteria as set out, and they didn't find any consistency with relating to vomiting as to non-fasting patients versus fasting. So what we currently know is that normal healthy children do not aspirate. Yes, they do have post-sedation emesis, but that is usually drug-related rather than procedure-related. And that certain patients are at higher risk for developing aspiration. And those patients you would in any way rather opt for general anesthetic. They also created a nice flow diagram or a treatment pathway, a decision-making pathway, which classifies patients into mild, moderate, and high-risk patients. And these can guide you as to whether you should be delaying the procedure to meet fasting guidelines or whether not. And one of the things, some of the risk factors that they identified was severe systemic disease with a constant threat to life. Severe obesity, which they classified as a BMI above 40, airway abnormalities, so your craniofacial abnormalities is quite important there, and then patients with esophageal disorders and bowel obstruction. Even severe systemic disease was not an independent risk factor unless there's a constant threat to life. So what we know is it's safe. We don't have to delay procedures and increase suffering for the patients to keep them not fast. And that's a big thing, not just for the patient, but for the parents and the whole unit, especially your nursing staff who has to care for the patient while they're fasting. Okay, thanks.
Thank you so much.
A couple of those of you, anyone's wondering why we tapped Cornell in for that.
Cornell, maybe you can send a summary of that to the group when you get it.
I will send the latest published paper.
That's amazing. Thank you. Okay, so like a Boy Scout, you can never be too prepared when it comes to procedural sedation. Let's talk about patient safety. So just like in adults, we should still carry out a pre-sedation assessment, check the past medical history, do a physical examination. Just because the patient is now a child, we can't just assume that they are well and have no comorbidity. So let's take that into account. And also remember that the ASA classification applies to pediatric patients too. The majority of patients that will present to the EC and require procedural sedation will have an ASA classification of 1 to 2. And the percentage of patients that develop adverse events with an ASA score of 1 to 2 is generally quite low, but it does exist. So rather be prepared than not. In terms of preparation, you need to take into consideration what you might need for your sedation, as well as what you might need if you encounter problems. Your common complications of procedural sedation include respiratory depression, hypoxia, apnea, emesis, hypotension. So you should be able to, first of all, identify those issues and then manage them as you go along. We said that Johnny's mom had given consent, so remember that you should still take consent. Yep. Usually from the parent, obviously, if we're dealing with pediatric patients, unless your child is old enough. And then if you've got a pre-procedure checklist in your unit, that would be a good thing to use. And you can go through that. A lot of the units have that sort of thing. Then your area, your environment. I would say you should be in a monitored environment. A lot of people don't, but I would stress that you should be in a monitored environment with access to resuscitation equipment, airway equipment, rescue drugs, and as well as the equipment and the consumables that you're going to need for the procedure itself. I would not draw up, but I would work out doses for all of your resuscitation drugs for just in case, and have them written there and in the back of your mind in case anything goes wrong. And then access to a fully stocked resuscitation trolley is ideal, but at least a variety of oxygen delivery devices, a bag valve mask, suction monitors, end-tidal capnography. We'll talk a little bit more about that just now. And IV access if you decide that is how you're going to give your agent to your patient. There are some people that will always want an IV line, and there are some people that are more relaxed about it. I'm one of the people that will always want an IV line. I like having a backup for just in case purposes, in case something goes wrong. But if you're not one of those people, and you don't necessarily always need that. You just need to have a backup plan in your mind about what you would do if you encountered a complication and you don't have an IV access. And yeah, in terms of planning, just have a plan A, have a plan B, and then with your humans that you're involving. So I would say at least 3 practitioners, healthcare practitioners, 2 doctors, and a nurse. One doctor will do the procedure, one doctor will do the sedation, and then you need a nurse to monitor and possibly fetch things. So probably always at least 3 people, unless you're using something like Entonox, self-administered sedation. But make sure your people that are helping you with the procedure and the sedation are all on the same page about what the plan is, what your plan A is, what your plan B is, what to do if a complication arises, and so that you're all thinking the same thing and going from there. Okay. Kat, do you want to take us through monitoring?
Yes. I lost you there for a second. I'm back. Sorry. Can you hear me?
Yes.
Okay, good. So just with regards to monitoring, there are so many shortcuts taken here, and it's completely unacceptable, basically, to summarize it. There's just no excuses to be taking shortcuts in this regard, and we need to be meticulous in your procedural sedation of patients. The absolute core basics, I think it's a given that saturation should be an absolute basic. However, probably not the most important thing. So our gold standard is waveform capnography. Okay. Now, most of our emergency centers, certainly at district level, have got that available, and yet somehow it's available and yet not used by all doctors, and it is not clear why. There's just no excuse for the end-tidal CO2 to be hanging from the wall and the patient not to be connected to it through some means when it is available. We do understand that certain facilities don't have available, and your role as advocates for child safety, you should be motivating, advocating for end-tidal CO2 to be available. So how do we do this? And then there are special connections available. So at Mitchell's Plain, we've got the sets. So you can either have the set that you use for an intubated patient or the set that connects to nasal cannula. That is already pre-connected. So that's fancy. That's not so available everywhere. But you can also do adapted with taping the your end-tidal CO2 to the inside of a mask or under the nose, etc. That's your sort of adapted way of using end-tidal CO2 versus the pre-designed ones, which are not available everywhere. So that's your gold standard. I'd say next in my priority order of monitoring is physical monitoring of the child's chest rise. This is really underestimated. I can't tell you how often we've walked into a procedural sedation halfway through and there's no one watching the chest and there's not end-tidal CO2 on. People are monitoring only ECG and SATs, which is just not acceptable. So remember, SAPS is your oxygen saturation is a time machine, told us what is happening a while ago. It is not a reliable way of measuring respiratory rate. So please, someone needs to be watching the child's chest. Candice spoke about having a team. You shouldn't have the whole team watching the child's arm that's being reduced. You need proper monitoring, and that involves people. And not just a junior nurse who's told to watch the SATs and tell me if it drops, and not just someone listening from the corner of their ear if the SATs is dropping. That is too late. So you need to watch, has the patient stopped breathing? And people will tell you things like, you'll say, have you noticed that your patient is not breathing? And they say, but the SATs is fine. Yes, the SATs is fine, but the patient is still not breathing. So this is absolutely critical. So waveform capnography, ideal. You can watch out for your respiratory depression, apnea. You also going to watch out for a flat line, because if your patient flatlines on your end-tidal CO2, it's either one of two things. It's either that the end-tidal CO2 is no longer connected to the patient, or it's a monitor problem, but that shouldn't be your default. Your default should be, do I have central apnea? The patient is not breathing as a result of the drug that you've administered. Do I have an obstructive apnea due to airway collapse or positioning, versus do I have laryngospasm? Okay, so this is critically important. So waveform capnography, we know that that's not everywhere. Where that is not available, where the tool is not available, you should, number one, advocate for it, and number two, be meticulous in your clinical monitoring of respiratory rate and respiratory effort. All right. And then saturation is your next most important monitor. Okay. Now there's a lot of controversy, oxygen, no oxygen, lot of discussion. We can have a debate for half an hour on that. But if you've got meticulous monitoring of respiratory rate or capnography, waveform capnography, you can pre-oxygenate your child. That's perfectly acceptable. And oxygen throughout. However, bear in mind that putting on a rebreather mask, sedating someone and monitoring only SATs without monitoring your effort of breathing and looking for signs of laryngospasm, you can put yourself into big trouble. Because if you don't pick up that they're apneic, and you only pick up their apneic because they have desaturated profoundly whilst already being on a rebreathe and mask, you are in huge trouble. So it's not an excuse. All right. So meticulous monitoring of chest rise and fall. And the team must be ready to jump in and stop the procedure and act as needed. All right. So that's a very brief overview. I'm not going to go into great detail. This is a whole talk on its own, monitoring. But if you can just remember one thing, which is someone needs to look at the chest or look at the CO2 or both. But this is absolutely no excuses. Okay. Right. We still want to leave time for discussion. So we've got just a few slides left, and then we're going to time for discussion, debate. This is a conference on its own, this topic, but we want to give just some practical things, tips, and then we can chat more afterwards. Okay, Candice, go ahead.
Okay, so let me go through this quickly. So ketamine, this is ketamine. When it comes to sedatives, you get dissociative and non-dissociative sedation. Your non-dissociative sedatives operate on a dose-response continuum. So the higher the dose you give, the progressively deeper the patient goes into their sedation, which may result in respiratory and cardiovascular compromise. You can drop their level of consciousness. They become unconscious. But with non-dissociative, your non-dissociative sedatives that you often use, or that we all often use, include your opioids, your benzos, propofol, etomidate, barbiturates. But then you get your dissociative sedatives, which is basically ketamine. And when it is given in dissociative doses, it doesn't operate on the sedative continuum. It doesn't affect your cardiovascular system as much. You don't get respiratory depression. Your airway reflexes stay intact most of the time. And that is why I think we love ketamine so much and we rely on it so much. It's a phencyclidine derivative, and it acts by binding on your NMDA receptors and antagonizing those. And we love it so much because it gives us a little bit of everything. It's anxiolytic, it's amnesic, it's got analgesia, sedates patients. It's got a very, very wide margin of safety, which is very helpful in the emergency center when there's a lot of other things going on. Most of the time, your airway reflexes are maintained, and like I said earlier, your cardiovascular state is usually preserved. Your blood pressure and your heart rate can go up a bit. That's not usually a concern in this type of setting. For intravenous ketamine, we will give 1 milligram per kilogram, but the important part here is to give it very, very slowly, over at least a minute. If you give it as a very quick bolus, you increase your chances of laryngospasm. That usually works quite quickly, over 1 to 2 minutes, maybe 3 minutes, and then you get your nystagmus. And if you need to give a top-up dose, you can give a top-up dose of 0.5 milligrams per kilogram. With your initial dose of 1 per kg, you should get your horizontal nystagmus and then loss of response to verbal stimuli. And then you're able to do your procedure. Hopefully your procedure is very quick because your ketamine wears off very quickly, as I'm sure you all know, after about 20 minutes, and then the patient should have full recovery by 60 to 120 minutes. The odd complication, so you can have apnea. It's very rare, 0.3%, but with, as I said, very rapid bolusing. 1% of patients might get noisy breathing, but you can just do an airway maneuver, which will correct that. 0.3% of patients can develop laryngospasm, but a very, very small percentage of those patients will go on to requiring intubation. And then your emergence phenomena, which is more common as your children get older and become adolescents. Your side effects or challenges that you might have with ketamine, and I would speak to the parents about it beforehand. If the parents are staying in the room for the procedure itself, I would tell them exactly what's going to happen, that baby's eyes are going to start moving around. They might get a little bit agitated. They might have a few involuntary movements. They might have some nightmares. None of this is long-lasting. It's all self-limiting. It doesn't usually cause any long-term problems. And a small percentage of them might vomit afterwards in the recovery period. And I think it's just easier to warn the parents about that beforehand than having to deal with that discussion while it's happening. Drug adjuncts to ketamine. So in the past, there used to be talk of having to give a benzo with the ketamine to prevent emergence phenomena. That's no longer a thing. It can increase your risk of adverse events, for example, respiratory depression and apnea. So you wouldn't give it prophylactically. If your child does develop emergence phenomena, severe emergence phenomena, then you can give a very small dose of benzo to treat it, but not prophylactically. People also used to give atropine because ketamine can give you a bit of secretions. That's also no longer recommended. If your child is at high risk of vomiting, you can give an antiemetic. So children that have had ketamine before and vomited, children that have had anesthesia before and vomited, other children that have had maybe doses of opioids before the procedural sedation, you might want to give them some antiemetic. And then the only other drug adjuncts I would say that you need are your emergency drugs. So what you might treat your laryngospasm with and what you might need to intubate with, and your resus trolley drugs, and have your doses written down for all of those and ready. There are a few contraindications to the use of ketamine. I would go through those in your own time. The most common ones would be children younger than 12 months, children with a higher risk of laryngospasm, and then those with significant cardiovascular problems, congenital cardiac abnormalities, and then if they've had a previous adverse reaction to ketamine. And then just another note on ketamine, I like it IV, but there are a variety of routes to give it. You can give it orally, you can give it IM, you can give it intranasally, actually, as well. Often the reason why we can't give it intranasally is because we're limited by volume because of the concentration of it. As Kat mentioned earlier, you can only give a maximum of 1 ml per nostril, so that often affects what drugs we can give intranasally. And then if you are going to give it by a different route, you just need to realize that you're giving a different dose for a different route, and the times to onset and peak and duration of action will all be different.
Sorry, I've got my mic back. Okay, so just to talk a little bit about laryngospasm, because we need to be very good at this, and we can often be called in a crisis. So someone else is doing a procedural sedation and you get summoned. Candice already mentioned the slower administration of ketamine. This is very badly done, and watch yourself. The 1 milligram per kilogram dose, okay, should be generally given over 60 seconds. So if you are giving a high dose, should be slightly longer, but just bear in mind over 60 seconds. And that often is not the case, especially if you've got a child that has not been well analgesied. So they've come in, a fracture, hysterical screaming, someone pins them on a bed. We've all watched this movie before. Next thing you know, someone's poking them with a gel coat to put up an IV line, the child's screaming, and then they're like, let's just quickly sedate them. And then, boom, the ketamine's in. So number one, risk of apnea, as Candice mentioned, but also higher laryngospasm risk. So it should be given over 60 seconds. So look at your clock. Again, an advocacy thing. If your department doesn't have a clock with a second hand, you should have one. If there is no clock with a second hand, how is anyone counting respiratory rates? I don't believe everyone's taking their phone out for every child assessment. Give it over 60 seconds, not rapidly with a flush, as is often given. Candice mentioned already 0.3% of children receiving ketamine. Now, the key to reversal is the application of CPAP with good basic airway maneuvers. Okay. Now, how do you give CPAP? Well, you can use an ambu bag with your PEEP valve connector on it. So it has to have PEEP valve connector. Again, if you don't have that in your resus trolley, then it should be got. And that should be part of your preparation. You shouldn't be hunting for it at the time when you have a child with laryngospasm. So CPAP with the PEEP valve on your ambu bag, and you do what's called a modified jaw thrust maneuver at what they call the Larson's point. So Larson's point is a pressure point at the top of the ramus of the mandible, and they call it the laryngospasm notch or the Larson's point. And so get your ambu bag with a PEEP valve on and then put pressure at this Larson's point. It's unclear about the mechanism behind why it works. There's some different theories. Number one, some people say it's just doing a jaw thrust. It's the jaw thrust that does it. Number two, it's you providing a deep, painful stimuli, which causes the vocal cords to relax. And the third theory is you're stimulating some deep cranial nerves, which happen to also stimulate the vagus nerve. Okay, so just to show you where is this Larson's point. It's not at the point that you normally would do a jaw thrust. Larson's point is in the notch here. Let me find a picture for you there. Okay, it's right up here. It should be right at your pinna. Okay, so at your earlobe, in this little notch here, feel it on yourself. That is your Larson's point bilaterally, the so-called laryngospasm point or Larson's notch. Okay, and you should be putting hard pressure there. So this is just one step, but obviously laryngospasm is a whole approach. I'm going to quickly show you a video of the Larson's point, and then we'll talk about the rest of laryngospasm.
Laryngospasm, a common complication after extubation, can be treated by the Larson maneuver. To perform the maneuver, first locate the laryngospasm notch behind the lobule of the pinna of each ear, anterior to the mastoid process of the temporal bone, and posterior to the ascending ramus of the mandible. Press the middle finger firmly on the notch in a cephalid direction. Some degree of jaw thrust may also be applied.
Okay, so, all right, this is just one thing you're going to do. So essentially, you are going to start pressure in this area. Anytime you think the laryngospasm, it's part of a differential. You look at the patient's chest, you see that there is movement, but there is a flat line in your intertidal CO2, and it appears like there is hard breathing. Okay, then you're going to be doing some things simultaneously. You're going to be applying your CPAP with your PEEP while doing a jaw thrust and pressure on this pressure point at the same time. And you're going to ask yourself some questions because how emergent you do the next steps it depends. Number one, is there desaturation? If the patient is already desaturated at this point when you're picking this up, proceed immediately to paralysis and intubation. This is a reasonable approach if you are already in extremis, you're already sat in the boots, because you as emergency medicine registrars might step into this situation halfway through. The cosmos call you, the patient's desaturating, they don't know why, there's panic, and you might step halfway through here. If the saturation, however, allows, okay, start by deepening the anesthesia. This is obviously if your initial pressure on Larson's point jaw thrust approach has not worked. So you haven't had a response within, the Larson's point should take about 3 breaths before you have release of laryngospasm. So it's a very rapid thing. You're not going to try Larson's point pressure for 10 minutes. Okay, then you can try by first deepening the anesthesia, and propofol is your traditional agent of choice, a dose of 0.5 milligrams per kilogram IV. And this is one of the reasons why it is ideal during procedural sedation to have an IV line. So even if you are going to sleep through some other means, when you are now asleep, to cite an IV. If there's no response to deepening anesthesia with propofol, plus all your other measures, then you have to administer an IV paralytic. Now in theatre, they might give an IV paralytic and then not intubate the patient. They might bag them until the paralytic wears off. Now that's obviously a different environment to us. They are going to give a low dose sucks. They're going to break the spasm. They're going to bag the patient. This is a fasted patient, an elective theatre procedure, etc. However, in the emergency centre environment, I'd probably recommend that if we're reaching the point where you're going to give a paralytic agent to a laryngospasm, that you should probably intubate the patient. And then, of course, extubation also puts you at risk for laryngospasm. So this is a patient that should only then be extubated as a very planned thing with the right team around. So most patients would never reach the point where they actually need a paralytic agent, etc. Most patients with laryngospasm, those who've experienced it, will respond to Larson's notch, bagging with PEEP, or just providing PEEP, and the vocal cords will relax. But you need to know what next, okay? And it's propofol, and if that doesn't work, then you're going to have to bag. You're going to have to give a paralytic agent. So it's just a very brief overview of laryngospasm. As future emergency physicians, you should know this really well in a lot more detail than I've just brushed over now. But this is, if you don't know to expect this, you will panic if it happens. Because people say, no, but the patient's breathing. You're just seeing chest movement or abdominal movement. You're not the patient's not actually moving air. All right. Candice.
Emily, how are we doing for time?
We've got like 2 minutes.
Oh, great. Okay. Internox. So we just thought we'd throw in a few options that we don't readily have available and see, just in case you come across them at some point. Internox is one of them, or nitrous oxide, as it's also called. So there's two options. Either it's piped into the wall and given out the wall and in a variety of concentrations, or it comes in the canister mixed in a 50-50 mix, so it's a 1-to-1 ratio, and then it comes with a demand valve, so it's nice for older children that can self-administer it. Very rapid onset, rapid offset, very good safety profile. Wouldn't give more than a concentration of 50%. Even though it's still self-administered, I'd still do with monitoring, and I'd still do with a team of people, probably at least still 2 people. And then just to know about side effects, nausea and vomiting can be quite common. So up to 10% of children receiving the 50% dose. The higher the dose, the more likely they are to vomit. They can get dizzy, they can have nightmares. None of this is long lasting. And then I think you all probably know the contraindications to nitrogen. And because it's mixed with oxygen, it diffuses through the tissue quite a lot faster than nitrogen alone. So it expands in all those air-containing spaces quite quickly. So any pneumothoraces, pneumocephalus, GI stories, I wouldn't use it. And also contraindicated in children that have a risk of vitamin B12 deficiency. It inactivates a B12 dependent enzyme and depletes your B12 store. So a very random fact, but just be careful of that. And then our last drug that I want to do quickly, dexmedetomidine. So dexmedetomidine, I'm not sure if anybody has worked with dex before. Anyone? Yes, no? In adults, nope, yep, okay. Dave, where did you use it? Red Cross ICU, COVID ICU, not children, okay. All right. The only place that I have, very good for COVID, is it a cure? The only place that I've come across it in my career so far has been in Red Cross ICU for the post-op patients. I've never seen it in an emergency center, but it's a great drug. And just to be aware of it, it's highly selective alpha-2 agonist. And it provides sedation, anxiolysis, analgesia, and sympatholysis. It's increasingly being used for sedation in children, but in South Africa, I think it's off-label for that use. I've worked with it only as an infusion. It doesn't have too much of an effect on the respiratory system, keeps the airway patent, and ventilation is usually maintained. And its way that it works mimics endogenous sleep. So if you stimulate the child, they should still kind of be rousable. Just a side note that it interferes with your thermoregulation, so just watch them for hypothermia. And because it is an alpha agonist, you have to keep an eye on the cardiovascular system. This, I mean, is not my go-to for procedural sedation in the emergency center, but because it's something different and we don't come across it often, we thought we would just touch on it very, very quickly like we have. Kat?
Should we try to do a rapid run through? So, all right. So that's the end of our talk component. But let's just go do a quick run through of the basics. Let's see if I can do this from the top of my head. So, essentially, children are undersedated and under analgesed typically. They do not get enough analgesia. We need to assess pain, consider mild, moderate, and severe types of pain. Mild, our simple approach, the Kat and Candice approach, paracetamol. If no response, add ibuprofen. You've got moderate pain, give paracetamol and ibuprofen. And if no response, then add your Valeron or Tilidine drops. Severe pain, imagine the patient's pathway. They come into the emergency center crying, hysterical. Start your distraction maneuvers, make sure they're facing away and don't see scary things. Parents are with them. They get intranasal fentanyl along with their paracetamol and ibuprofen. They settle, they get their arms splintered, they get the Emla cream popped on 2 sites that are suitable. They head off for their imaging or further tests and triage and all those things. They come back, the Emla cream is working, they get their ketamine, they're drip sited and their ketamine sedation in an adequately prepared unit with good monitoring, including end-tidal CO2. If that's not available, then meticulous monitoring of respiratory drive. And then fasting. Cornell's given us a great summary of essentially we don't need to worry too much. Maybe think a little bit about procedures that aren't done in emergency centers in other parts of the world, that maybe this group of patients might not be counted in on that literature, and know what to do if you get a complication of laryngospasm and how to manage it. And then think about alternative options. Internationally, fentanyl intranasal is being used with Internox for your basic forearm fracture reductions. That is a very, very common thing. Other alternative things to think about for suturing, think about your local anesthetics, your topical local anesthetics that can be used. Red Cross have got them available to soak in your wound before suturing. Also think about other things like in femur fractures, children can get nerve blocks. ultrasound guided, and there are other options available. Be an advocate for children. Just because we've always done it one certain way doesn't mean we always need to do it that way, and motivate in your various departments to gain access to things that we certainly have been able to get access to at our district hospital. That's it. I don't know. Now we can take questions. Candice, what else to add to my very quick summary?
Nothing to add to your summary. Just a small random thing from me. I'm not great at memorizing doses of things, and because we're consultants now, we can make posters of whatever we want and chuck on the wall, but not all of you can do that yet. I love it's called drug doses, but if any of you are old enough to remember the Frank Shan book, it's basically the Frank Shan book in an app. It's a paid app, but it has doses for everything in it, as well as resuscitation doses, antibiotics, like everything, how to bake a chocolate cake. And if there's an app that you're going to pay for pediatrics, I think that's the one. And it just takes a lot of anxiety away from having to try and remember doses off the top of your head when you're in a bit of a stick. Questions? Comments? Emily?
Kat and Candice, thank you so much for this talk. I know it's a lot to cover, and I think you guys covered a lot in just an hour and a half. I just want to open the floor to anyone who's got any questions, just to raise your hands, or you can post in the chat. I see Dave McAlpine has a question. Can you please turn on your camera, Dave? Thank you.
Cool. Hi, thanks very much for the chat, guys. That was actually really, really cool. Just a quick question with laryngospasm. Do you not recommend trying to bag through it at some point? So obviously if there's spasming, you'll do your jaw thrust, you'll put your mask on with your PEEP. And if that isn't relieving, rather than going full on for propofol, would you not recommend we try and bag them through it first? And if that's failing, then go on to kind of what may end up being your RSI?
Personally, yes. You've got the ambibag already on the face. The PEEP is connected. I mean, you don't have long to faff and think about the meaning of life. So yes, I would try and bag through. And there are different schools of thought on that. There's even the oxygen thing for procedural sedation. If like the only yes, pre-oxygenate your patients for procedural sedation, but it's very dangerous to pre-oxygenate if no one is watching the respiratory rate and no one's watching the that's critical, because then by the time you start desaturating on a well pre-oxygenated patient, when no one's been watching the chest, you're in trouble. But the laryngospasm, yes, I definitely try bag them through. I'm not saying I'm a world expert on laryngospasm and pediatric sedation, but yes, I would try. It's going to take a bit of time while your colleagues are drawing up things and getting stuff ready. So, yeah.
One more question. So if we don't have atomizers, which no units really do have, is there any value in giving it like a try just with the Gelco, or should we just not do that?
So you can. There's a very nice graph where they've actually done this. They've administered intranasal drugs through a variety of means, like drops, like dropping it in the nose in drop form versus a thing. I'll see if I can find that graph and put it onto the thing for you, and you can decide for yourself. I'm not saying don't give it, but you'll see that it is less. You lose more drug. And you can decide for yourself if you're willing to use that amount of drug and try the other route. Yes, you can try it. It won't make. And then remember, people to also do a sort of adapted things with nebs and all sorts. The best is to get an atomizer, and they're cheaper than a Gelco. So it's really it's a matter of. I promise you, if you print out and it's going to come to you guys as as the documents after the talk, but if you print out this state tender document, it's a matter of literally the consultant filling in a form, stapling the state tender document to it and submitting it to supply chain, and then they will get. It's that easy. It's not a fancy thing.
Okay, cool. Thank you very much. Thanks, guys.
Thanks, Dave. I think we have another Dave. Dave Kluti, do you have a question?
Dave Kluti will always have a question. It's going to be about pathophysiology.
Or a comment.
That just hurts my feelings. I'm not going to turn my camera on because I look hideous.
No, turn it on, Dave. Turn it on.
God, okay. Oh, it is on. Hello. Hi, guys. Thank you for that.
Sis.
McCulban, your question's over, and you are the second Dave, just so we're clear, but that's another story for another day. Guys, I just want to ask, because from what I understood, and I had this debate when I saw one, but using your lignocaine-soaked gauze, like some guys are big fans of it. I was told by another charming individual that no, there's no literature to back it up, and most of them end up needing intra or see, I'm very my school. Just needs to get lignocaine infiltration anyway. So do you guys use it quite a lot? Or, you know, are we throwing ahead? Is it just kind of to make ourselves feel better?
So I don't use the lignocaine gauze thing, but maybe Candice can speak more about private stuff just now. So I don't use that. But what is important is that if you're giving lignocaine to a kid, so they do talk about buffering your lignocaine with a bit of bicarb to make it burn less is the one option. The other thing is use the tiniest needle possible and give it really slowly. Now, because the slower you give it, the slower the tissues expand, which is what causes the painful thing. So you can buffer lignocaine slightly or and use the tiniest needle possible. But this lat stuff that I did use at Red Cross, it's different to your lignocaine-soaked gauze, and it can be put in the wound. But as long as it's you have to have read about how to administer it.
So LAT is a combination of lignocaine, adrenaline, and tetracaine, and it's all mixed together, and it's very easy to give at Red Cross as it is. I don't think any of the other units have it. I've never seen it anywhere else. I haven't even seen it in private. Dave, I've never seen any literature on the poor man's lignocaine on gauze. It's just really anecdotally, I found it worked for me for open wounds, but then I would just remember total dose. I would give a little bit of it in the gauze, put it on the open wound, and then I would subtract that from the total dose, and I would still end up infiltrating a bit, but it takes the sting away a bit from when you do infiltrate, and it worked quite well for me. But that's really just anecdotally. It's not anything I found in the literature.
And you can use adrenaline, or with or without, it doesn't matter. I mean,
I
think you can use adrenaline, yeah.
You can, yeah.
Cool, thank you very much.
Having the adrenaline in is that you can see the skin and tissue start to pale when it's working properly, because then you can actually see, oh wait, it's goes like sort of pale around the edge of the wound. But yeah, it might be that, like Candice says, you put that in, which makes the injection of the local less painful. I think everything when you're thinking about pediatric pain and pediatric sedation, I know it's probably been said a million times, but just think about, if this was my own child, what would I like? And really want your child tackled to the floor and held down by 4 people and people just stitching that forehead. No, it's not what you want. So just think about it that way whenever you think about pediatric pain and stuff. And I've been a culprit of it as well.
Sure. Thank you very much. Thanks, guys.
Thanks, Dave. And I think we have one more question from Camden, please.
Hi. Thanks, Kat and Candice. This has been a really cool session. I really like the interactivity. I've got more of just a comment on the EMLA stuff. And I mean, it's similar to the pushback we get sometimes by saying we should actually provide local anesthetic before doing an arterial blood gas in adults. So there's this thing called the peak end effect, which is what I didn't know as an intern. You always thought you needed to do something quickly, get it done and get it over with. But in fact, the psychology of it is, and there's quite a lot of literature to back it up, is that human beings, including children, assess a painful experience based on just two things, which is the peak and the end. So what was the maximal amount of pain reached, and then what was the last thing that they remember from that experience. So if you can find a way to lengthen out that procedure by giving them small amounts of pain for a longer period of time, and the last thing them having to remember being more pleasant than the initial state, you actually improve their whole pain experience, and they're more likely to have a more pleasant experience coming back to the emergency department. So that whole thing of as soon as they come in, you know, applying the EMLA, letting them move around to a different place, even though you may think it's taking longer, but I mean, you can do other things in the meantime. It actually provides a much better, something else going on here. It provides a much better sort of evidence base for lengthening out rather than just taking a needle, sticking in it quickly, and then having a high spike, and then the kid never likes to come back to you ever again. That's all. Thanks.
Anyone else?
I don't see any more hands. Can I just clarify one thing with you, Kat? In terms of your laryngospasm, once you've tubed them, is it a long-term tube in terms of you're going to have to transfer from your district hospital to PEDS ICU, or is it just a safe place to extubate with someone to re-intubate in case they spasm again on extubation?
Yeah, so what we would do with Mitchell's plane, which isn't necessarily always the right thing or whatever else, but for a child that was intubated purely for laryngospasm from a procedure that was minor. I'm not talking about a super sick child. I'm talking about a kid that was getting a foreign body removed from somewhere, and now they've laryngospasmed and end up tubed. We would probably move to theatre, and in conjunction with us and anesthetic consultant together, or us in theatre, but giving a more controlled environment, whatever, we'd probably extubate there. You know, it all depends on your current facility, unit, whatever. But these are things that you should ask in advance. You know, these isn't something that you should be discovering under fire. You know, this is something we've briefly chatted to anesthetics about. Like, you know, if we had to intubate a child with grade 3 croup or whatever, you know, there are different things at different times of day. But these are considerations we should have. Is it, wait, could we do this in a more controlled manner? Certainly an extubation for a laryngospasm, I wouldn't send them in an ambulance to Red Cross to be extubated there. That wouldn't make logistical sense. Bear in mind that if you extubate and everything is fine, you're going to send the kid home. So you don't need an ICU bed. But I think that's just the message there. That being said, I haven't treated thousands of laryngospasms, and I shouldn't do, because at 0.3% of all sedations, maybe in my retirement day, I would have reached that many. But if I'm still at Mitchell's plane.
Awesome. Thanks so much, Kat and Candice. Thank you, guys. It's been an amazing session. We do have our feedback form that we're going to post on for everyone that's keen. So please, if you really enjoyed it, please let us know. We definitely want Kat and Candice back. So please just let us know. And thank you, guys. Thanks. Have an awesome day.
Put your cameras on and wave goodbye, please.
Yeah,
we missed having everyone at Mitchell's plane for teaching. We miss all your faces. And we hope that next year soon. We hope that next year soon we'll be able to recommence the Mitchell's plane like monthly teaching sessions physically at the plane. So hopefully next year we'll be able to see all of you there.
Yes.
Give us. We won't see you there next year. Okay. All right. Thanks, everybody. Candice, should we stay on to just chat to the facilitators?
Goodbye.